Well, thank you all for joining us today. The Fitzhugh-Mullen Institute for Health Workforce Equity is kicking off a series of discussions with experts on emergency health workforce policies to address COVID-19. Today, we're talking about federal and state preparations, particularly around the 1135 waivers. My name is Candace Chen, and I'm with the Mullen Institute. And today we have two real on-the-ground experts on health policy. We have Sarah Rosenbaum, who is the Harold and Jane Hirsch Professor of Health Law and Policy in the Milken Institute School of Public Health at the George Washington University. Sarah is a national expert on Medicaid, private insurance, and healthcare access for the medically underserved. We also have Suzanne Swagner, who is a senior health policy analyst with the Washington State Healthcare Authority. And when we spoke earlier, Suzanne, you mentioned that you're also a nurse by background.
Yes, I am.
Thank you both for joining us today.
Thank you for having me.
So with the developing COVID-19 pandemic, we're seeing an increased focus on the health workforce, on the very important issue of protecting health work, but also increasingly looking at how do we maximize the current workforce? How do we bring new workers into practice to meet the increasing demands of COVID-19 and to maintain ongoing essential healthcare services? Because problems like cardiac disease, diabetes, mental health, they're not going away all of a sudden. Today, we're talking about federal and state efforts to prepare the health workforce with a focus on the 1135 waivers. Sarah, I'd like to go to you first. What is the 1135 Waiver Authority and why is it important?
Thank you, Candace. Good to be with you all today. So 1135 refers to Section 1135 of the Social Security Act. And it is a special grant of power to the Secretary of Health and Human Services to essentially take a series of steps during a declared public health emergency like the one we are in to essentially suspend or set aside various requirements that otherwise would apply to the Medicare and Medicaid and CHIP programs, having to do with who is a qualified provider, where can the provider provide services, and what services can be paid for. So it is essentially an emergency retooling of all the laws that normally apply under Medicare and Medicaid to regulating the delivery of healthcare itself. And it's done in order to allow the healthcare system to adapt to the emergency and to get paid for and bill for things that otherwise would not be permissible under Medicare and Medicaid or CHIP because they are conducted in a manner that does not meet the requirements of the program.
Great. Now, on March 13th, CMS announced the number of blanket waivers available to all states based on the 1135 authority. Can you talk a little bit about what's in those blanket waivers and what does this mean for states and organizations?
Yes. So in the case of Medicaid, Medicaid requirements, especially requirements for providers, the definitions, the scope of what's permissible, the description of what conditions have to be satisfied before a provider will get paid. Often those Medicaid conditions are linked to Medicare. So if you are a Medicare certified hospital, you would be a Medicaid hospital, presumably. And you can't be a Medicaid hospital except in rare circumstances if you're not qualified to participate in Medicare. So there's a lot of back and forth between the two programs, and that means that when you have an emergency like this, the secretary can issue what's called a blanket waiver, which is allowed under the Medicare, under 1135, and say, we're putting all of these changes into place effective right away now, having to do with the Medicare program. And that saves states the time and burden of having to reapply for the very same waivers. Essentially, the HHS secretary is signifying that these changes are already in place, so you don't have to worry about them to the extent that Medicaid follows suit. It will follow suit if you choose.
Can you talk a little bit more about the provider location and the provider enrollment waivers and what what kind of flexibility that gives organizations?
Sure. So in a lot of states already, Medicaid is a very flexible program, and much more flexible actually than Medicare. And so a lot of states may already give their participating providers, or at least certain classes of providers, all kinds of flexibility. You can provide care in homeless shelters. You can provide care out of a van. You can, provide services in schools. You can go into an assisted living facility and see your patients there. Lots of states already do that to some degree. This would essentially open up more flexibility, and the stimulus bill actually makes clear that one of those flexibilities would be telehealth. That telehealth would be a site flexibility, so that you could treat a patient remotely. Provider enrollment, often, and I'm sure this is an issue in Washington State, it's an issue in virtually every state except maybe Hawaii and Alaska. There's contiguous states, for example, and you may have people going to a provider. We have this, of course, we are in Washington, D.C., not Suzanne, but Candace and I. And we have a population that travels all the time. Marylanders travel to DC, DC travels to Maryland or Virginia. But in order to get paid by an insurance company, and this is not unique to Medicaid or Medicare, you've got to be enrolled. And so this is designed to ease some of the restrictions on who can get paid for services before all the activities involved in enrolling as a provider, getting vetted, getting approved, happen. And so, of course, it's done, again, in order to enhance access.
Great, great. Now, in addition to the blanket waiver, states, we know, can request additional flexibilities through the 1135 waivers. Can you give us an idea of what, and we'll talk a little bit more about Washington State specifically, but what additional flexibility states are requesting, what's being approved, and maybe more importantly, what's not being approved?
Well, for example, a state might want to, and it's, what a state can do as a state option versus what a state can do under 1135 versus what a state can do under the other large waiver authority, 1115, gets a little murky. The point of 1135 is that you can fast track things. So actually, Washington State has an interesting element in its 1135 waiver to adjust payments to managed care organizations because of the emergency. There may be a surge, and they're going to have to pay their downstream providers more, and they're going to blow through what has been this carefully calibrated actuarial soundness cap. So that would be an example, or to add provider locations. To add certain kinds of services that normally aren't covered, to recognize them as a covered service, even if they're provided off-site, or to broaden the definition of a service. So the whole system to allow hospitals or require hospitals to add beds that are outside the scope of the beds that their license certifies them to offer. Everything's regulated. So the hospital's license would say we have 500 beds. And of course, in New York State now, the governor has ordered all of his hospitals to double their bed capacity. So this allows Medicaid to pay for all the additional bed capacity, even though they're not licensed as such. So that would be an example.
Now, I am going to ask a follow-up question because we hear a lot about payment, right? And how the federal policies for Medicare and Medicaid CHIP relate to states and to healthcare organizations is a lot about the payment. Why is payment important in this?
Well, it's important because the revenue has to keep coming in. I mean, it's very interesting. I do lots and lots of work with community health centers, or federally qualified health centers as they're known under Medicare and Medicaid. And two things have happened to them at once. It's sort of like a double whammy. On the one hand, they have this, 5-alarm emergency going on in their communities. On the other hand, thousands of patients have disappeared because people are frightened. They're frightened to come out. A colleague of mine here in Washington, D.C., who runs the city's largest community health center, literally had to shut his dental practice. Everybody canceled their dental appointments. Now, these are very important services, and 4 months from now, we hope everybody will get rescheduled. But for now, the revenue connected to the dental component of the health center has literally disappeared. And so what do? Do you keep some revenue coming in, certainly for the things that are covered and needed? And also, of course, this is where grant funding to providers such as a health center would be very important, because how do you keep paying staff if the revenue has declined so badly? And so providers, particularly community-based providers, whose time is so desperately needed, are finding that the things that they're customarily offering to their patients are not wanted at the moment. Everybody wants the emergency service, but they can't pay people.
Great. Thank you so much, Sarah. I'd like to turn to Washington State now. And in Washington State, in the 1135 waiver request, there were actually a number of additional requests made around facility and workforce flexibility, around telehealth, around financing, and around community supports. And I thought that there was a very important point made on workforce in the waiver request. And this point was made in regard to flexibility and how home health certifications and initial assessments are performed. And I don't know if anyone ever thought that I would be reading out of a waiver application, but I actually want to read it, where they say, this will allow patients to be cared for in the best environment while supporting infection control and reducing impact on acute care and long-term facilities. This will also allow for maximizing coverage by already scarce physician and advanced practice clinicians, and allow those clinicians to focus on caring for patients with the greatest acuity. And when I read that, I was struck by this idea that, and this need that so many of these requests are about being able to provide the care communities need in the safest way possible, and about protecting and maximizing the healthcare workforce. And so there are some specific health workforce requests as well that I think are worth mentioning. They're around flexibility for teaching physicians and residents and getting certified nurse aides into practice more quickly. Suzanne, can you tell us more about the Washington requests and why are they needed and what are they intended to do?
Thank you. I'm happy to be here and talk about the innovation we're doing. One of the themes that runs through our waivers, as you said, is our commitment in Washington State to providing care in the place where people want and need to be for their residents. And in this case, the challenge that comes as we talk about serving people in communities and homes is how we do that flexibly in a way that allows us to provide access to as many people as possible. And as you say, provide safety for both patients and caregivers. So our home care waiver language is intended to do that by allowing assessments, certifications, et cetera, that are needed to start care and maintain care to be provided in a telehealth manner so we can gather and collect information and move people through the system in a more effective way. Particularly a challenge for us in Washington State because in addition to the dense city of Seattle and our sister city, Tacoma, where a lot of our issues are happening, our state has very vast rural areas where we need to serve people with long transportation times and high sets of needs. So this flexibility to serve by phone is really important so we can serve people where they are and not risk them or their providers in moving them out. The other thing that this does is it aligns nicely with our longstanding role as a leader in long-term and support services and allows us to provide services to our folks under Medicaid waivers under 1915C to increase and better serve people in homes who really want to be there and may not have the resources or supports to be there. So we're focused on doing that at the same time. Again, doing the right thing for everybody is really important. The other thing that this focus is the commitment we've made through an 1115 waiver that you discussed earlier that we have around transformation of our healthcare delivery system. In that waiver, we're focusing on two main issues and priorities, and that is integrating physical and behavioral health care and integrating SUD care. And in doing that, we are looking very heavily at how we can deploy our professional workforce to do two things: work better in teams, which the work around certification of home health aides and home health coverage does, and also allow people to practice to the top of their scope so that we can deploy them to the right places, which is really important in this emergency, so we get the right resources to the most acutely ill folks and still get people accurately and appropriately treated who may not have that acuity.
So there's two things that I want to come back to. Let me start with, you mentioned telehealth, and Sarah also mentioned telehealth. And there were a number of additional telehealth requests, including reimbursing for telephone visits at the same rate as video visits, allowing funding for providers to purchase their equipment, and a hold harmless provision for emergency telehealth services. Now, I think some of these, as Sarah mentioned, might be, are addressed in the stimulus package. But tell us why these things are important, and what you're trying to do with them.
So what we're trying to do, again, is to be able to deploy safely and effectively resources that protect, again, our patients and our clients, and also to reach people in places we might not have reached them, so they can they can continue self-isolation and quarantine, and or be reached in rural settings or other difficult to find places. For example, what do our homeless or almost homeless people do to provide and find care? It is important for us right now to cover those telehealth services at the same levels as a physical service, so that we are paying people adequately and appropriately to address some of the gaps in financing that Sarah talked about really nicely. When people are providing more of their care through telehealth, we want to make sure they get paid adequately and appropriately for those services, and we help them stay open and keep those doors open so they can continue to see patients. The other thing that does is also look at the kinds of telehealth that we may need to do in an emergency that may not follow some of the rules and regulations around types of telehealth equipment, use of HIPAA and security requirements, so that we can meet people. So how do we deploy and do phone and FaceTime and some of those kinds of technologies, so we can better reach people where they are, and not complicate it with rules that may slow us down in our ability to address the needs of our patients.
And then the other thing that I thought was really maybe unique about your 1135, about Washington State's 1135 waiver, was the community supports request, which I know is built off of your 1115 waiver, your district waiver. Can you talk a little, and my understanding is that the request is to allow Medicaid match for the establishment of a regional COVID-19 response initiative. Can you tell us a little bit more about what that regional response initiative would do?
At this point, what I know about is happening where that is being considered is in concentrated areas like our nursing home outbreak in King County that has reached on the national news. How do we establish a local and regionally focused emergency response team and deploy emergency and very different alternative care sites so we can meet high demand for patients where Medicare rules and regulations may have presented issues that slow us down in getting people into and out of the hospital? One example of that you mentioned around nursing homes is we've relaxed the requirement for a 3-day, or we are requesting the relaxing of the requirement for a 3-day stay before moving a person into a SNF, so we can move people who may have COVID issues quickly in and out, and free up beds for more acutely ill folks in those hospitals. So that's the kind of deployment we're looking for when we talk about being able to put these in a region. It's also important when we look at the fact that, as I said, Washington is a really rural state. We have very different public health structures and healthcare systems around our state, as I'm sure a lot of folks do, and the request for this responsive and flexibility allows us to design systems that meet the needs of a rural area versus an urban area, so we can effectively deploy resources and perhaps gain and share from those across regions if we need to.
So what I hear you saying is that a lot of these requests and a lot of the action that your state is taking is about needing flexibility and needing funding support to be able to ensure that you can get care to people where they need it in the safest way possible, both in response to COVID-19, as well as for the for the ongoing healthcare needs of your communities, whether you're talking about nursing homes or whether you're talking about primary care. And I think that second point is also really important, because if that care is not provided, then it's ultimately going to lead to additional burden on hospitals who are trying to deal with the COVID-19 cases. Is that fair?
That's fair. I think that the second point elucidates and kind of hits at, in our 1115 waiver for transformation of our system, we've developed regional authorities who work with partnering providers for our Medicaid clients to develop systems of care, to integrate care, to expand and integrate behavioral health care, to expand and integrate SUZE. That structure of separate regions, and we have 9 of them across the state that we call accountable communities of health. Those 9 entities have very different plans for how they work in their communities, and that structure gives us something to build on to do those regional responses.
That's great. Can I go back to Sarah?
Yeah.
Now, when we consider Washington State's waiver request, and again, it seems pretty clear that the states are looking for both flexibility as well as funding support to address this public health crisis, but also to maintain the healthcare providers and the systems for the longer term. What should CMS be doing in response to these waiver requests?
Well, in fact, they are approving the 1135 waivers at a rapid clip. That they've approved, I think almost half the states at this point have approved waivers. If I, had an observation, I would say that, and this is sort of always the legal reality of these things, that if you look at what Washington State wants to do, they want to do many things that may not be doable under 1135. And so very appropriately, the state has said, look, use whatever authority you've got. Excuse me, you've got. These are the things we want to do. This is what it's going to take. There are eligibility requests, there are cost sharing waiver requests. There's a lot of requests in here. But we've thought long and hard about what we have to do to adapt our system to where the needs are, and make sure that patients have access to care. And people who need access to care, get it enhanced. And Washington State's experience, which is, I'm sure, illustrative of the more ambitious state proposals coming in, is that some of the things they asked for have been set aside. And CMS takes the position, well, we can fast track 1135 and we have to give 1115 more thoughts, well, in fact, and this is something that we are now learning as a country about preparedness. By the winter of 2020, it was becoming very clear what kind of emergency we would be facing. And one of the things CMS could have done, because they've done it before many times, is to put out model 1115 waiver guidelines that would say to states, you can come in with a combined set of requests. They can deal with things that we use 1135 to do. They can also deal with the eligibility, coverage, other delivery issues that are specific to the emergency, but make up a whole package. And instead of thinking holistically, what they've tended to do is focus very specifically on their 1135 authority. And I would say that given the amount of time we're going to be at this, and given the fact that we have, not in Washington State's case, but we have 13 states that still haven't expanded Medicaid for all low-income people, and every state has uninsured people, and the marketplace is not going to open for a special enrollment period. That one thing states may be coming forward wanting to do is, of course, build on the uninsured persons testing option that was in last week's bill, in order to be able to say, for COVID-19 testing and treatment, we are going to put you temporarily on insurance. The CMS could allow that. and could also waive budget neutrality, which is a special concept that sort of holds states to a very strict budget in their demonstrations. But it's not a concept that exists in the law. It exists only in agency practice. And so the agency could say, you know what, for this emergency, we're going to let states spend federal funds over the zero-sum game that we normally use. And that's what they did during Katrina. And that's what they've done before. They just waived the budget neutrality issue in order to let federal funds flow to where they're needed without regard to whether on a net basis the state is paying more.
So it sounds like CMS has a good amount of authority here.
Oh, they have huge authority. Just as states have a lot of flexibility, CMS has enormous authority to put all of its waiver powers together in one place and say, come on in, and they, of course, we're 1135, we could see, they very properly issued a blanket waiver so that states didn't have to worry about that bundle of requests. They could just focus on other things. But what's missing at this point, I would say, is the kind of system that Washington State contemplates, which is a combination waiver system, where the state is not only trying to overhaul its delivery system, but they're trying to reach additional people who are sick and don't have coverage.
And Candace, this is Suzanne.
Yeah.
Sarah makes a really good point about the different types of waivers. We have submitted our 1135 waiver. We are just preparing to, or just have submitted a waiver to our 1115 that focuses on how we can use the structure of the demonstration that we discussed earlier to do some additional expansions. One of the items in there is around childcare and how we help support child and family care to allow and enable the workforce of healthcare workers to come and show up and be able to attend to services so that they don't have to worry about their family at the same time. And the issues you just described around expanding regional areas. So I think Sarah's point is really well taken. We're trying to take a look at where we can provide some backup and requests for waivers based on, incremental may not be the right word, but categorical approach that seems to be taking around, here's my 1135, here's my 1115. We want to serve people and we want to partner up effectively with CMS so we can serve people. And so we'll continue to work with them around what types of waivers are appropriate and how they fit our needs.
If I could add one more point about Washington State's waiver, the other very interesting thing, which you touched on, but I think it bears, underscoring, is the state's effort to use its Accountable Communities for Health system, which was developed in order to improve community health, to provide community-wide supports during this crisis. And there are a number of states that have these special waivers. They were launched during the Obama administration, and I don't know if they'll continue, but Washington State, to the best of my knowledge, is the first state to try and adapt its delivery system and payment reform waiver to the current crisis.
That's a great point, Sarah. Thank you. And I do want to turn, though, to the stimulus bill, which I know the Senate passed last night and has to go to the House. And there is funding for healthcare organizations, and there is funding for states, and there is, as you were, I think, mentioning earlier, additional flexibilities around and protections around telehealth. What is your, and I think it only became available, the language only became available yesterday, but what's your take on how much the stimulus bill is going to address some of the issues that have been brought up today? Is it going to be enough?
Well, certain parts of the stimulus bill having to do with cash in people's hands can get up and moving, it sounds like, within just a few weeks, and we clearly will still be in an emergency then. I think first of all, I am plowing through the fine print now, so I am not prepared to give you any intelligent read on, for example, what the state funds can do. There are already requests coming in, can we use the money to give people supplemental welfare checks? Can we use the money to give people extra Medicaid help, things like that, outside of the Medicaid program. But whatever's in here, and there are a whole bunch of things that needed reauthorizing. You and I were talking about that before, like the workforce authorities under the Public Health Service Act that are just in, they're a long-term feature of the Public Health Service Act. But by and large, these measures are designed to only modify things during the period of declared emergency. They do set a precedent. I mean, it would be nice if for some of these provisions, it would say during any declared period of emergency, as opposed to COVID-19, because we have emergencies all the time when things like telehealth potentially become very useful. But they didn't write it that way. They wrote it very specific to COVID-19, I'm sure, to keep the cost of the bill, under control. So there are a lot of incredible things in this legislation. Some that where clearly whatever gas they need to step on, whether it's the cash out the door or the direct money to the hospitals and the healthcare providers, that are just, do or die measures, literally do or die measures at this point. And other things where if the state gets the nod, yes, we're going to, like going back to last week, yes, we're going to let you cover uninsured people for testing. It may take a few months to get all the paperwork caught up with a new state option added to Medicaid, making it fly. But meanwhile, providers, because the application can be given and it's retroactive to actually prior to the date of application, providers can start billing and states can start paying because they know that the amendment's going to be approved. So the problem always with this is, turning battleships around in water. And I'm sure the Trump administration, the Office of Management and Budget, the M side of the Office of Management and Budget is getting every cabinet agency to sort of set out a timeline of what gets done this week, what gets done next week, what things have to get done, but it may just be dollars, federal payouts catching up with what's already underway.
But an important thing for us to watch, and an important developing thing, obviously. Suzanne, I want to give you the last word, which is as odd as it seems, your 1135 waiver went in about a week and a half ago, and I know, as you mentioned, the Washington State has also submitted an emergency 1115 waiver request, as both you and Sarah were talking about previously. As amazing as it sounds, COVID-19 is changing so quickly day by day. I wanted to give you the opportunity to talk about, over the last 10 days, at this point, what are your health workforce priorities from the perspective of the state? And what are the needs that you really have from the federal government?
So I think that the priorities would be the ability to flexibly deploy our various types of teams to address care in interesting ways. As Sarah said, being able to bill for telehealth and other services in flexible ways. We will be taking a look at how that works and how we can do that with the federal government. For us, one of the things that you see in our waivers is a focus on what comes again out of our Accountable Communities of Health and 1115 waiver around integration, and that is how do we build some capacity to serve people's social needs so that we address some social determinants issues to not only get people better, but to help keep them from getting sick. How do we get nutrition out? How do we do some of those kinds of things in working with our homeless population? Those are welcome things to have a conversation about. And I think the ability to keep standing up these alternate care sites and moving people into care sites we might not traditionally use. For example, the waiver, as you saw, envisions the ability to take beds from different settings. Let's say you own an ambulatory surgery center and you're a hospital. Could you use part of that to provide services for certain kinds of COVID patients? That flexibility will be really important because we're seeing big surges like in King County. We're starting to see one start. And another part of our state where we're having a nursing home outbreak that's really creating a demand on a system. So that flexibility will be really important, and that's part of why we have telehealth, so we can move people where the acuity is. Those things, that ability to get our providers trained up and moved around and get them done effectively. The one thing that will be interesting to watch, and I don't know if it's a federal government question, is how long the emergency lasts so that we can address some of the issues that exist around stay home, stay healthy, and the closure of classroom instruction and testing facilities and those kinds of pieces that might back up, particularly our primary paraprofessional level kinds of folks. And so that'll be, I don't know if the federal government can do other than to continue to work with us around providing flexibility, but a lot of that is a state-driven, statutory-driven piece. So again, it's the partnership.
So I hear a lot of thought and work going into making sure that there is the health workforce to address the increasing demands around COVID-19 itself, around making sure that healthcare systems and healthcare providers are maintained and can provide the other necessary and essential care to prevent people from getting sick and putting additional strain onto an already strained system. And then I also hear you saying that we need to be thinking, we also need to be thinking about some of the, we'll say, medium to long-term issues as well, that it's going to be important to make sure that our healthcare organizations are financially stable, viable through this, and then also implications for things like training. I have to thank both of you so much for taking the time today. What Washington State is doing, I think, is going to be a potential model for many other states, what states like New York, what states like California are doing as well. We will be posting this on our website along with links to resources like to the CMS sites, but also to the Washington Healthcare Authority site that has information about both your 1135 waiver as well as your emergency 1115 waiver. So I just want to say thank you so much to both of you for joining us today and for kicking off our series, in fact.
Thanks for having us.
Thank you for having us. We're excited to talk about what we're doing and to learn from others as we go. We appreciate that opportunity.